me to speak. You've heard from a number of very erudite and skilled speakers, and now you're going to hear from me. Before I start, actually, I am at Apodiki GP on Twitter, and I just want to do a little bit of a research thing. I'm going to get you to all stand up for me, if that's okay. Okay. And I'd like you to sit down if you didn't go into medicine to help people. Okay, thank you very much. That's great. I'd like you to sit down if you always wanted to be a doctor from the very as long as you can possibly remember. This is the best thing that you've ever, you always wanted to be a doctor. Okay, that's cool. That's good. I'm glad I'm not alone. That's really good. Let's take a picture of it. That's great. One more question. You can all sit down now. What I'd like you to do is put your hand up if you want to be better than average at doing your job. There you go. So have a think on the answer to that last question. So yes, I've been a GP in Apodiki for 24 years and medical director at Pinnacle Mental Health for 8 weeks. My conflicts of interest is a traditional thing to do. The most important conflict there is that I'm not an expert on this, but I have been involved in clinical governance activities personally, professionally, with my own practice in PHOs and at a national level in various organisations through most of my time. This afternoon, I think where I sit here is in sharing some personal stories around clinical governance, to help perhaps consolidate some of the ideas that you've heard from the cleverer speakers that have gone on before me. So what I'm going to aim to do is to share with you the context of primary care and how clinical governance works, share a few thoughts on what I think is missing from our current received wisdom as well. So I was brought up in Liverpool in the UK. First home was demolished in the sun clearances, and we moved to a road where the back of our house there was an old railway land with ponds. We used to go catching sticklebacks and collect frog spawn, which would grow into frogs in the backyard. I'll come back to that later on, believe it or not. This is me with my mum and dad, an older brother on a beach, and I'm around about 5 there, and I want to be a doctor at that stage. And for me, it was all about chocolates. Because my dad was a charge nurse on a ward in Walton Hospital, and from a very young age, one of my jobs was to come in and help him share out the chocolates that were gifted to the staff on the ward. And I thought, wow, this is an awesome place to be. What more could a kid want? By the time I came to sort of thinking about medical school, the prime driver was still getting chocolate, but I worked out that that probably wouldn't get me through the interviews, so I looked around for some other reason. I've had a very liberal Catholic upbringing, and so I sort of thought, well, actually doing good, that might be a good thing for us, and I see that I'm not alone in wanting to do good. That was part of my motivation. Okay, I know what to answer, I'm there to do that. But I also did a little bit of research, and I found out that there was a shortage of GPs in the UK at the time. And despite the fact that our own family doctor was the grubbiest man I'd ever met, who constantly smelled of a mix of tobacco and antiseptic, and who literally kept his tongue depressor in his top pocket and reused it, I knew that my chances would be better if I told them I wanted to be just like him. At the interview, they asked me what I thought a GP did. So I couldn't really tell them what I thought, which was just sitting down all day smoking, using Dettol as an aftershave, putting dirty sticks in the mouths of kids with sore throats and giving their mothers pills that made them sleepy in the day, but less likely to hit them. So I just sort of made some stuff up, and I thought, oh, frog spawn. So being a GP is like being a frog on a lily leaf, I thought. The world is like the surface of the pond, and the GP's lily leaf covers part of the pond, and it's next to another frog on another lily leaf, and that one's next to another lily leaf, and then another, and almost covering the whole of the surface of the pond. And the frog looks after the leaf because, well, that's what frogs do. And although the leaves are all circular, they cover most of the pond, which is the people, apart from some places where they don't, and the people aren't covered. But that's what being a GP is like. They offered me 3 Bs, so that was awesome. That's 3 Bs, sort of that 3 As normally, 3 Bs. That's what Sheffield wanted. So if we accept that interview panel thought this analogy was a superb representation of what being primary care is all about, what does the frog actually do, and how does it relate to clinical governance? So what the GP actually does is to care for a defined community. I think Barbara Starfield, who's a heroine of primary care research, she didn't refer to frogs in her sort of analysis, but she talked about the 4 C's of primary health care: accessible contact, it's comprehensive, continuity of care and coordination. So, and I hope that all of you have been exposed to general practice in your training so far and understand that it's the place where generalists work, providing continuity of health care to people in the context of their family and their community. It's primary care is the totality of care that happens outside of a hospital, and it's where 98% of care actually happens. The GPs are members of a multidisciplinary teams that support people to self-care and help people prevent ill health, promote well-being, and deal with the issues when life takes a bad turn, whether that's social, emotional, relational, or physical. We all help people to achieve health and well-being. Primary care is that first port of call, the doorway into services, and one of the joys of being a GP is that you never know what's going to come in through the door. So it's a lot of fun. This is our team at the Tertiary Surgery and Neurology. So, as we all agreed before, we all came into this because we want to care for people, and we want to do that really well. We want to do it better than average. And really, I think that we should actually be aiming to be good enough. Clinical governance is the process which enables us to be good enough. So it's a system through which organisations are accountable for continuously improving the quality of their services, safeguarding high standards of care by creating an environment in which excellence in clinical care will flourish. So this is another definition of clinical governance. It's the system and framework that supports that framework. We talk about pillars of clinical governance, and the Best Practice Advisory Centre describes 6: clinical effectiveness, which you've heard about; quality assurance, which we've touched upon; provider education and development; clinical audit and continuing quality improvement again. We've heard about risk management and a little bit about research and development. I'm a doctor of very little brain, and so I find it really hard to remember 6 things all at once. And I'm showing you this before I've shown the people at Pinnacle, because I'm only 8 weeks into this actually. So just but this is what I think we should be really focusing on. I've condensed the 6 pillars of clinical governance down into 4. Taking a leaf out of Wellington Free Ambulance's book, and with the help of Kate Wang, the quality manager at the College of GPs. So clinically effective systems, using systems like primary options, clinical audits and pathways, to really focus on excellent outcomes. We really want our patients to be safe. And that is about accreditation, meeting the standards of our colleges, identifying the risks and dealing with those through adverse incident analysis, providing a great patient experience. That's about, again, listening to what the patients say, hearing what they have to input into our system, listening to their compliments as well as their complaints. And the final pillar of this, which is about the member experience, the great member experience. This is where I put sort of education and training, research and development. But I also think there's an element in there that we really do need to focus on. And Stephen sort of touched on it earlier, with that picture of the very unhappy doctor sitting in the corridor. And I'll come back to that and more frogs later on. So I'm going to share a case study, because that's what we do in general practice. This is a story of Amy. I've changed her name. Who presented with hematuria to the emergency department at the beginning of this year. She presented to the ED after talking to her mum, who's a nurse, about her symptoms, which had been going on for at least a month, while she'd been holidaying and partying pretty hard around Thailand, I have to say. Her PV bleeding was thought to be related to the gel that she had in place. It was just an ordinary period. The hematuria for a month and persistent cough with fresh blood in her phlegm. The ED doctors found nothing very remarkable in her past medical history. She did admit to smoking just 5 a day, which is probably an underestimate by fourfold. And she admitted to binge drinking twice a week, which again was probably an underestimate by fourfold. The examination findings in the emergency department were, again, pretty unremarkable, but they organised a whole range of tests, which were sent to me in a discharge summary there. They demonstrate a mild neutrophil leukocytosis and slight renal dysfunction, and she had dipstick proteinuria and hematuria. Chest X-ray was clear. ECG was done for some reason, which was normal. So that was discussed with the medical consultant, who felt that this could be post-streptococcal glomerulonephritis, and she was discharged to me as her GP for follow-up, which she did 4 days later. And I read that discharge summary and felt, okay, I'm following up somebody who's got probable glomerulonephritis. She was feeling a lot better. There was, again, nothing very much to find on examination. She did look a bit dehydrated. She wasn't able to produce a urine specimen for me that morning. These were her blood tests she'd had the day before, which showed persistent neutrophil leukocytosis and some renal dysfunction. I planned with her to do daily reviews, and we talked about some lifestyle issues. Subsequently, we had a urine specimen dropped off by her boyfriend 3 or 4 days later, which had lots of blood and protein in it. She wasn't able to attend for whatever reason, and got represented 11 days later, feeling very sick. She got a lot worse. She came in because she'd vomited up blood twice that morning, and felt that was probably worthwhile talking to a GP about. Again, apart from she looked ill, there wasn't really very much else to find. My plan at that point was to send her into hospital, saying she's a young person with PV bleeding, blood in her sputum, blood in the urine, now hematolysis, and looking unwell. Anybody going to guess what the eventual diagnosis was? Oh, a clever person with grey hair. Anybody else? Nobody else know what the takers? Clever person with grey hair? Goodpasture syndrome. Well done. Gosh. This is Goodpasture syndrome. So something that happens to a GP once in every 250 years. For this poor woman was unfortunately she didn't quite fit into all of the characteristics of it. Although symptomatically she did. You know, if you think about it. Her chest X-ray was normal. She was a little bit unusual for that. Later on, she did develop consolidation and so on. She was a smoker. She didn't admit to cocaine, but I wouldn't be at all surprised. And as you remember, Goodpasture syndrome, the prognosis is usually quite good. Unfortunately for her, she's not on the good, having a good prognosis. She's now on renal dialysis and on the kidney transplant list. So I'm going to come back to the issues this raised for me in my practice and the hospital and how we dealt with it. But I want you to remember that this is what clinical governance is about in primary care. Through clinical governance, we should be able to create a system that responds to situations like this and is accountable for continuously improving the quality of our services. We should be creating a system that's safeguarding high standards of care, creating a system and an environment in which excellence in clinical care will flourish. In order for clinical governance systems to work, we know that clinicians should be at the centre, and that they should be dealing not just with risk and quality, and that the proceedings should be open and transparent. So where did we go wrong with this particular case? I think there was an element of familiarity bias. We know what common things happen commonly, good posture syndrome is not a common thing. I would admit to a lack of knowledge. I remember hearing about good posture syndrome in 1985 when Stephen was driving his fancy car. But those rare conditions, they very rarely leap to mind. I can see a number of places where communication errors and problems added to this issue between the ED doctor and the specialist, and particularly for me in the lab system incompatibility. If you go back to those slides, you'll see that there's quite a change in their renal function from the ED discharge to the day 3 renal function. But our systems don't match, and we have to go in to a completely different system to look at the hospital system, and to flick from the hospital discharge letter to the GP lab letter. There's systematic problems there. And I think another big problem for all of us is that this is happening in an ED department and in a GP clinic where there are 101 other pressures on all of the staff. So what systems do we have in place that keep us accountable for continuously improving the quality of the services and safeguarding those high standards? What do we create? How do we create an environment in which excellence in clinical care flourishes? So at a practice level, we have, through the College of GPs Foundation and Cornerstone standards, and ensure that we have processes in place that make us focus on the quality of care and aim to continuously improve what we do. We've got professional requirements that encourage us to think outside the box and to look at the things we don't know, and to review our practice and share that review with others. And in practice itself, we're part of an interprofessional team that enables us to see our clinical activities through the eyes of other professionals if we're having our regular team meetings. Practices face challenges in clinical governance in providing time for discussion and to make it enjoyable to do those things rather than a chore. And that's especially true if the owners of the practice are seen to be separate from and oblivious to the patient care, which is sadly the case in some corporate-owned general practices. PHOs can provide structures through which clinicians can have significant influence on how we do things. Again, I haven't shared this with Pinnacle yet, but I'm sort of trying to get an idea of how clinical governance works within this organisation. Our clinicians, it seems to me, to be involved at almost every level in the organisation, other in the corporate and the administrative division. So, which is, I think, is pretty impressive. It's my job apparently to glue all of that together, so I need to talk to you later on. So PHOs often have processes that help us to share best practices, to identify the outliers and address the issues, and to support people as they deal with complaints and share the learning that comes from that. Primary care, we do need to be engaged with our PHO. We should read the newsletters and look at the websites, and welcome the support staff to our practices, and attend the education meetings. We should take part in the audits and use the practice decision tools that are provided for us. PHOs have got lots of processes that advance our care and provide improvement and review of clinical outcomes. And yes, we do need to be engaged with those systems. On a macro level, I won't go into the detail of this, but I believe that clinicians should be involved at every level of the health service. Some of the larger PHOs have the capability of looking at issues like this and taking these sorts of challenges into regional and national discussions on behalf of our patients. So many DHBs have introduced GP liaisons and primary care nurse leaders who provide a conduit for primary care issues to be raised into the centre and increasingly recognise the value that well-supported primary care can bring into the hospital themselves. DHBs have got internal processes as well that look at continually improving their safety. The best systems have that whole-of-system approach and support PHOs and GP practices to do more closer to home through investing some of the savings that they make back into primary care. But that might be another story for another day. And of course the wider system, we've talked a little bit about the Health and Disability Commission in Australia. We have one here, and the clinicians involved with the Ministry of Health, some of whom are here today. So what does it really mean for me personally as the frog though? So one of the definitions of professional is to be a self-regulating body, and last time I looked, and I don't look very often, I had a body. As a professional, I have a responsibility to be self-regulating, a reflective practitioner. I need to consider the outcomes of my actions and my interactions and aim to continuously improve the quality of my services. I should be safeguarding the high standard of care and creating an environment for me in which excellence of my care will flourish. So yeah, I need to engage with my college's maintenance of standards process, not just because it's required, but because I want to continuously improve the things I do. I need to audit my care to help me look for the things I don't know, and follow my professional development plan that encourages me to look at the areas of my professional life that I wouldn't normally look at. I should be up to date and aware of new things and prepared to do more postgraduate diplomas. Maybe not. But certainly be prepared to learn how to do ultrasound and other procedural things in medicine, because that's where the future is going. Also need to be really on top of social media. I'm going to tweet your pictures just before. Because that's where our patients are, and we need to be really all over that interface. We need to be understanding virtual medicine really, really well. But self-care, I need to be looking after myself. I teared up just before when I was talking about that patient because it's really very personally affecting. I was personally devastated by what happened to that woman, what's happening to her. So I need to recognise that. If I'm tired, if I'm angry, if I'm upset, I need to be really looking after myself. I need to be drinking less alcohol. Doing more exercise. I'm sleeping more. Reading a novel every now and again. What happened for this particular patient? I had a specialist phone call. I hope the kidney specialist isn't in the room today. But he said, if you'd sent her in 10 days ago, I could have saved her kidneys. So that prompted me to seek what I call a professional conversation. Professional conversation is a structured process whereby you agree some rules around with a trusted colleague around confidentiality and openness and transparency, and you talk through whatever the issue is. And he sent me home for I was at home for a week and a half at that point. At the end of that professional conversation, I took the case to my peer review group, 2 different peer review groups that I'm part of. Peer review groups, for me, I've been involved for 20 odd years, a very trusted group of friends, really, who are very critical and go into in-depth around the case. I can take the records in, I can show them exactly what happened, and they basically said, well, by the grace of God go I. We also ran a significant event process internally to look at what had happened, to do that, or what do they call it, root cause analysis, and look particularly around our follow-up systems and our communication within the practice. I then attended the hospital mortality and review committee, actually the first time a GP had ever done that. And that was really useful to bring my perspective into what had happened. And consequently, there's been some discussion about making the laboratory test results more compatible. I also sought advice and review from the Medical Protection Society, who I've always found really, really helpful to support any sort of complaint or issue. Really a great organisation to be part of. And for the self-care, I've been having a support of a psychologist and drinking less alcohol, reading a novel. So as you move forward today and tomorrow with the work that you're going to do, what I'd like you to do is to consider the personal nature of clinical governance, the reactive things that you do that create quality outcomes, enable you to learn when things go wrong, and the proactive things you can do to engage in clinical governance activities before events arise. Question the workplace you're in. If it doesn't allow you the space to be reflective, if it's not courageous enough to adapt to the changing needs of health professionals in our increasingly agitated pond, where the fishes are demanding more and more and the pond keeper is giving us less and less. Without your expertise and involvement, it's all just going to be a bureaucratic exercise, and you provide the real-world experience working in that system that makes the system work. Get engaged with it and make it a professional goal to sit on at least one committee and contribute to at least one clinical governance activity in the health system in your life. You don't know, you might enjoy it. I'm really surprised there's somebody touched on this a little bit earlier. I've got two final sort of ideas which I'd like to share with you for the future. So this is the IHI AAA, which is this is its adaptation for New Zealand health system here. This idea has driven our health strategy and agendas for 10 years or more now. We say our systems need to focus on improved quality, safety, patient experience, improved health and equity for all, and best value for the resources. That's all great. Well, it turns out that if that's all you focus on, and there's quite good evidence that this is what you end up with. You end up with dissatisfied patients, overuse of resources, high staff turnover, inappropriate prescriptions, reduced concurrence, lower empathy in staff and worse clinical outcomes, and increased errors. The key element which is missing from the AAA that addresses those problems is improving the work life of the healthcare providers, clinicians and staff that work within the system. If we don't do that, we don't have a quadruple aim, the system isn't going to flourish. And there's a lot of evidence, strong evidence, that clinician happiness improves a large number of outcomes, from pain and readmissions to physiology and mortality, trauma outcomes, and healthcare costs. It's amazing, really, how much the impact of reducing burnout and improving compassion can have on the system. So that's a key thing I'd like you to take into your discussions. So monitoring yourself for that anger into your personalisation, looking after yourselves, getting enough sleep, eating properly, exercising. I've missed out alcohol for some reason. Look after your primary relationships. So, look for resources like the computer-aided learning for the mind from Auckland University and Tony Fernando. I've been listening to a thing called the Doctor Paradox podcasts. Everybody podcast, really great idea. He talks a lot about rediscovering our passion in the work that we do. Look up the work of Robin Youngson and Hearts in Healthcare. He's a New Zealand-based anaesthetist who's an international expert in compassion. Take those conversations into your clinical governance. So the second big issue, going back to our frogs, is the fishes. And you make this clinical governance. The fishes, who are the people, they're very often missing from that conversation. Patient voice in clinical governance grounds the clinical conversations that we have, and it stops us from getting embroiled in doing things above average, and it actually keeps us being good enough. And it works for GPs, specialists, hospital administrators and managers. It's really important that we don't miss the patient voice and patient experience in our clinical governance conversations. What I hear is, well, I'm a patient, I've been a patient, I take statins and an aspirin, and it doesn't really work that way. recently, our practice staff, we had our strategic planning day. So we all went out into the streets of a Portuguese and asked 3 random people what they thought a good GP service looked like, what we should do more of and what we should do less of. And people came back and we sort of collated it. They basically said we're doing a great job. They wanted us to focus on after-hours care and at the same time look after ourselves because they could see how much pressure that we're under. So, in conclusion, airline support crews always tell us in the safety briefing to put our own masks on before we help the children near us, and we need to do the same thing with clinical governance. Clinical governance in primary care starts and ends with the integrity and well-being of the health professionals involved. If we continue to see the systems imposing quality standards and audits to help bean counters, then our patients and us, we will all suffer. The most important clinical governance is perhaps the most neglected, that it creates an environment in which excellence in clinical care can flourish. And it can only flourish if you look after yourselves and don't lose the passion that led you to be a doctor. And if you feel that passion ebbing, then change something. Thank you very much.